Not so complicated, and it's day 8, clinical case discussion 8. And without delay, let's begin our case discussion. So a 38-year-old male presents to the emergency department with a 4-week history of fatigue, night sweats, and left upper quadrant pain. He reports a 5 kg unintentional weight loss, recurrent low-grade fevers, and easy bruising over the past month. He denies recent infections, travel, or medication use. Past medical history includes mild asthma, uses albuterol PRN, and family history is notable for a cousin with lymphoma. It is probably a case of tumor, that even a blood cancer, and he is a non-smoker, drinks alcohol socially, and works as a software engineer. Okay, the vitals are BP is normal, HR is slightly raised, and RR is normal, SpO2 is 96% is normal, and temperature is 37.8 degrees Celsius normal. And on examination, on general examination, he was pale, fatigued, and there was no distress. And in hint analysis, that is head, ear, eye, nose, and throat, there were no lymphadenopathy, no mucosal bleeding, conjunctival pallor. And in cardiovascular examination, normal S1, S2 heart, no murmurs, lungs were clear bilaterally, and abdomen showed splenomegaly, spleen palpable 4 cm below costal margin. That may be the reason for left upper quadrant pain, right? And no hepatomegaly, mild tenderness in left upper quadrant, and in the skin there were multiple ecchymoses, which are bruises in the skin or tissue or mucous membrane. On arms and legs there were no petechial hemorrhages, and in neuro examination he was alert, oriented, and no focal deficits. Let's see on labs. CBC, WBC is markedly raised, so it is a case of leukemia, and 60% is blast, that is too high, and 20% is lymphocytes, 15% is neutrophils. Hemoglobin is low, platelets is 45,000 per microliter, it is a case of thrombocytopenia too, and peripheral smear shows numerous blasts with high nuclear cytoplasmic ratio. And errors are noted. Chemistry, LDH 800 units per liter, which is quite high, which signifies that there is a very high cell turnover. And uric acid 9.5 mg per deciliter, normal 3.5 to 7.2, and creatinine 1.3 mg per deciliter, potassium 4.6, calcium 9.0, and then albumin 3.5. Bone marrow biopsy showed hypercellular marrow, 70% is blast, positive for myeloperoxidase enzyme CD13 and CD33, and negative for CD19, CD20, TDT, which is terminal deoxynucleotidyl transferase enzyme. Yeah, and in cytogenetics there is translocation of 8 to 21 chromosomes and Q22 Q22, and it is also RUNX1 and RUNX1T1 fusion. Also coagulation profile seems quite normal. PT 13 second, INR 1.1, PTT 32 second, and fibrinogen 300 mg per deciliter. What is the most likely diagnosis, and what is the next step in management? ALL, AML, CLL, CML, APL. These are the options that often confuse us, right? So we will debunk each of these options and their differential diagnosis in our upcoming slides. Let's debunk the first option, which is acute lymphoblastic leukemia. ALL is an acute leukemia of lymphoid precursors with greater than 20% of lymphoblasts in blood or marrow, right? And it generally presents with fatigue, bruising, and organomegaly, similar to AML, but blasts are lymphoid. That is, they are not myeloid blasts, and TDT positive, CD19 positive, CD20 positive is present in here in ALL, right? And our rods are generally absent, and cytogenetics differ in adults, which is translocation of 922, not the translocation of 821. So this is not the case of ALL, and this patient's blasts are myeloperoxidase positive, CD13 positive, CD33 positive, and TDT negative, confirming myeloid lineage. So it is not a case of lymphoblastic leukemia or lymphoid lineage. And also ALL is more common in children, and adult cases often involve lymphadenopathy or CNS symptoms not seen here. Unlikely. So this is very unlikely. And I have attached an histopathology in here. You can see in red Zimsi stain on marrow spirit. There you can see mature lymphocyte, condensed chromatin versus blast, open chromatin, that in the first circle, in large circle, and also plasma cell clock face chromatin you can see there. And mitotic figures, obviously, they are the indicators of excessive mitosis which occurs in malignancy. And the FAV classification is done for acute lymphoblastic leukemia too, but is in AML, just like in AML. We will talk about it later. But in lymphoblastic leukemia, there is L1, L2, and L3. The morphology of L1 is homogeneous blast, regular nucleus, homogeneous chromatin, small or inexistent nucleoli, mild basophilia. And in immunophenotype, B cells is generally CD19, CD22, CD79A, CD10, CD20, IgG, immunoglobulin, cytoplasmic or superficial. And T cell, CD3, CD7, CD5, CD2 or CD4. And in L2 type, there is irregular nucleus, heterogeneous chromatin, and large nucleoli. B cell, CD19, and you can look at the tumor markers there. And in the L3 type, there are large blasts and prominent nucleoli, abundant cytoplasm, baculation covering the nucleus. That are the differences in the morphology in 3 different types. And the second option we have is acute myeloid leukemia. And since we already know that this is a case of myeloid lineage, it might be the answer. And in acute leukemia with greater than 20% blasts in PVS or peripheral body smear, here is greater than here is 60% of blasts, so it matches. Or bone marrow, and also in bone marrow here is greater than 70% blast. And so and myeloperoxidase positive, CD13 positive, CD33 positive, which all are present, and all rods are pathognomic for AML, which are also present, and myeloid markers are also present. And the translocation of A21, Q22, Q22 translocation, and RUNX1 to RUNX1T1 fusion is a favorable risk AML subtype core binding factor for AML, seen in 5 to 10% of cases, often in younger adults, right? And in clinical features also match this scenario. And elevated LDH and uric acid suggest high cell turnover, as I said it already, and creatinine rise may reflect tumor lysis syndrome. We'll talk about it later. So this is highly likely. And you can see the histopathology in here. There are neutrophilic myelocyte in early stages and neutrophilic myelocyte in late stages. You can see or notice the difference there. And neutrophilic myelocyte in early, you can look at this, and erythrocytes, the changes in erythrocytes, the erythroblasts are also seen, and band neutrophil are also seen in here. Polychromatophilic erythroblasts are also seen. So we'll hold on this. And the third option we had is chronic lymphocytic leukemia. Since it is not a case of lymphoid lineage, this is not obvious, this is not the case, this is not the option, right? But we will still tap into this. CLL is a mature B-cell malignancy, typically in older adults greater than 60 years, but our patient is 38 years and presenting with lymphocytosis WBC greater than 20,000 per microliter, which fits in here, lymphadenopathy and hepatosplenomegaly. Bone marrow shows less than 10% blast, which is very far from the case we presented. And peripheral smear shows small lymphocytes with small cells. These small cells are the high yield thing in CLL. You have to remember this, right? And this patient's youngest 38, high blast count 60%, all rods and myeloid markers positive, exclude CLL obviously, as we talked earlier. And CLL lacks cytogenetic abnormalities like T or translocation at 21, and it's not associated with significant anemia, which is 9.2 gram per deciliter hemoglobin or thrombocytopenia at diagnosis. And the acute presentation and marrow findings are inconsistent with CLL's indolent course. So this is very highly unlikely. I have attached the pathogenesis here. There is hematopoietic stem cells, then CLL hematopoietic stem cells, and then B cell progenitor that is turned naive, and GC B cells, post GC, CDS, CD27 and MBL, and then CLL. This is the typical features. And in early immature and then mature phase, there are 2 phases. In early immature phase, there is lymphoid lineage priming and expansion, and in mature phase there is clonal selection, expansion, and clonal selection and transformation. That is what it occurs. And in the fourth option, there is chronic myeloid leukemia, CML. This is very typical, very high yield thing, and this is most probably the most asked questions in USMLE PLAB, because of this typical Philadelphia chromosome thing. And CML is a myeloproliferative neoplasm, BCR to AVLI fusion gene due to translocation of 922, which is also called Philadelphia chromosome, and it presents in the chronic phase with leukocytosis, WBC 50,000 to 200,000 per microliter, mature neutrophils and myelocytes, right? And anemia, thrombocytosis is what occurs, but there is thrombocytopenia in our case, and splenomegaly. Symptoms include fatigue, weight loss, and abdominal discomfort. Peripheral smear shows a left shift, that is, myelocytes or metamyelocytes increase, but less than 20% is blast, which is far away from our case, and bone marrow is hypercellular with less than 10% is blast in chronic phase. Progressing to accelerated phase, 10 to 19% are blast crisis, greater than 20% resembling AML or ALL. This may bring confusion, but there are typical features in the chromosome we can distinguish entirely with ALL, AML, right? And in the disease progression of CML, I have attached it here. There are 3 phases: the chronic phase, accelerated phase, and blast crisis. And chronic phase, it typically occurs for 5 to 6 years, 10 to 15%, and asymptomatic. And in accelerated phase, there are new cytogenic abnormalities, and it prolongs for 6 to 9 months, 16 to 30%, and fatigue, tiredness, and splenomegaly. And in blast crisis, there is increased genomic instability, 3 to 6 months, and then greater than 30% cases. Increases blast cells in marrow and blood, and they also may cause extramedullary disease. The last option we have is acute promyelocytic leukemia, APL. APL is actually the subtype of AML and M3 subtype in FAB classification. We will talk about it later, and is driven by translocation of 1517 forming the PML RARA fusion. Presence with greater than 20% is promyelocytes, not typical blasts. This alone excludes this from our consideration of the options. Our rods and severe coagulopathy, DIC, prolonged PTR, PTT, then low fibrinogen are the typical features of this disease, and coagulation parameters are normal excluding DIC. APL typically expresses CD33 strongly and responds to all trans-retinoic acid, which is ATRA, all trans-retinoic acid. It responds to this. And the splenomegaly and lack of promyelocyte dominance and smear further distinguish this from APL. In histopathology, there is heavy cytoplasmic granulations as seen in generally stains red or purple and may obscure nuclear border, and there are multiple OR rods in some cells may resemble bundles of sticks, and also round or oval, frequently centric nuclei can be present, and occasional clefts or indentations can be seen in the nuclei, and moderately condensed chromatin and indistinct nucleoli can be seen. So our diagnosis is AML, acute myeloid leukemia, and the mechanism of AML is actually there is TAML and BAML, right? And then TALL, BALL. So basically in AML, the mechanism goes like this: founder mutated hematopoietic stem cells, normal hematopoietic stem cells within the bone marrow niche, and then treatment with genotoxic agents like alkylating agents, topoisomerase 2 inhibitors, antimetabolites, antitubulin agents, PARP inhibitors, and ionizing radiation. They cause pre-T-AML that causes expansion of founder mutation, survival advantage with or without acquisition of new mutations, and then that progress to the acquisition of driver mutations of chromosomal lesions. And these drugs here, these genotoxic drugs here, has a mechanism of DNA damage, mutagenesis, chromosomal lesions, structural or numerical, and effects on the bone marrow microenvironment, and T cell abnormalities or dysfunction. The clinical picture of AML normally presents with fatigue, fever, frequent severe nosebleeds, night sweats, and bone pain or tenderness. Unexplained weight loss is a typical feature of malignancy, and excessive or easy bruising that is due to thrombocytopenia, and enlarged labor or pain. Frequent or severe infections, swollen lymph nodes. That this is the typical spectrum of clinical features of AML. And FAB classification system of AML, as I said earlier, there are M0, M1, M2, M3, M4, M5, M6, and 7 classifications, and each of these has different distinct histopathological features that I have attached in here. You can look at that. And in management of AML, induction chemotherapy, we have to do chemotherapy, and the regimen to be initiated is 7+3 regimen. Cytarabine 100 to 200 mg per meter square per day, continuous IV, days 1 to 7, and daunorubicin 60 to 90 mg per meter square per day IV, days 1 to 3. Translocation 8 to 21 AML is favorable risk with high complete remission, CR rates almost 80 to 90%, and then add gemtuzumab ozogamicin 3 mg per meter square IV day 1 for CD33 plus positive cases to improve outcomes if available. And in supportive care, we have to transfuse packed RBCs because hemoglobin should be maintained greater than 8 gram per deciliter, and platelets target greater than 20,000 per microliter for bleeding prophylaxis, and monitor for febrile neutropenia, prophylactic levofloxacin 500 mg daily, posaconazole 300 mg daily for fungal coverage. And we have to also manage the tumor lysis syndrome, right? And hydration should be done. IV normal saline 2 to 3 liter per meter square per day to maintain urine output greater than 100 ml per hour. And allopurinol should be given 300 mg daily to reduce uric acid. If TLS becomes severe, potassium becomes greater than 6 milliequivalent per liter, or phosphate greater than 4.5 mg per deciliter, we have to use rasburicase 0.2 mg per kg IV once. Monitor electrolytes, uric acid, creatinine every 6 to 12 hours. And in electrolytes, potassium 4.6 milliequivalent per liter is borderline, restrict dietary potassium, and monitor. And also we have to correct hypocalcemia if it is present, right? And there is consolidation therapy post CR, or if the complete remission occurs, then after achieving CR, we have to do we have to administer 3 to 4 cycles of high dose cytarabine. AML has so low relapse risk, so allogeneic hematopoietic stem cell transplant HSCT is reserved for relapse or high risk features. Monitor minimal residual disease, use qPCR for RUNX1 and RUNX1T1 to detect MRD. Post-induction or consolidation, persistent MRD may prompt HSCT. And we also have to address complications like infections. We have to treat fever with broad-spectrum antibiotics, piperacillin, tazobactam, 4.5 gram IV Q6 hour if neutropenic, and culture blood, urine, and sputum. And also in bleeding, we have to treat ecchymosis and thrombocytopenia requiring platelet transfusion. If bleeding is severe, maintain platelets greater than 50,000 per microliter. And here is the difference between different types, right? ALL, AML, CML, and CLL. The age in ALL is childhood. Actually, the incidence increases in childhood, and then adults incidence increases with age. And in CML 45 to 60, incidence increases with further ages, and in CLL is very elderly. And CBC, hemoglobin is low, WBC low or high up to 100,000, lymphoblasts greater than 20%, platelets low or normal. And in AML, hemoglobin is low, WBC low or high, median is 15,000 per microliter, and then myeloblasts are greater than 20%, platelets low or normal. There are similar features in here, but there are distinguishing features that helps us to differentially diagnose them, right? You can see this. And in CML, hemoglobin low or normal, WBC 100,000 to 250,000 per microliter, and myeloblast less than 10%, platelets high usually, granulocytes, neutrophils, myelocytes, basophils, eosinophils increased. And in CLL, normal or low, WBC 15,000 to 100,000 per microliter, and mature lymphocytes of the single lineage in proliferation. And the risk factors of ALL is Down syndrome, radiation, Epstein-Barr virus infection in infancy, and in AML, Down syndrome, Fanconi syndrome, pesticides, alkylating agents, radiation, MDS, and then unclear. In CML, radiation, cigarette smoking and increased blast crisis risk, and then in CLL, radiation. Lymphadenopathy is common in ALL and rare in AML, rare in CML, and common in CLL. Genetics in good prognosis is seen in translocation 12 to 21, but bad prognosis in 9 to 22 in ALL, good prognosis in 8 to 21 inversion 16 in AML, but bad prognosis in translocation 15 to 17, good prognosis in translocation 922 in CML, that is Philadelphia chromosome, in 95% cases. And in treatment, we have to give benztristin plus dexa plus anthracyclines in ALL, cytarabine plus anthracycline, FB SCT in AML, and imatinib in CML, rituximab and fludarabine in CLL. That is the very high yield table that I presented, and here's the clear cut concepts for leukemia differential. Last thing that we will gonna be discuss today. And blast percentage, acute leukemias, AML, ALL, there is greater than 20% blast in blood or marrow, but in chronic leukemias, as in CML, CLL, there are less than 10% blast because they are in chronic phase, mature cells dominate. And in APL, greater than 20% is pro-myelocytes, not typical blast are seen. And lineage markers, AML has myeloid lineage markers, myeloperoxidase positive, CD13 positive, CD33 positive, and RRODs possible, right? They are not always present, they are possible. And ALL, lymphoid, TDT positive, CD19 positive, CD20 positive, and there are no RRODs. And in CML, there are myeloid, mature granulocytes, and no RRODs. And in CLL, mature B cells, CD19 positive, CD5 positive, and no blasts. And this is our last slide. In cytogenetics, we have talked about AML as translocation 821, 15, 17, APL inversion 16, and in ALL 922, 1221, CML 922 but Philadelphia chromosome, CLL trisomy 12, del 13q, no acute leukemia translocations. And in clinical course, acute AML, ALL, APL has rapid onset on weak severe cytopenias, organomegaly are variable. And in chronic CML or CLL, insidious months to years, milder cytopenias, lymphadenopathy or splenomegaly is common. And treatment, AML chemotherapy, ALL, and we all talked about this earlier, right? And that is it for today. Thank you for staying with me until now, if you are staying, and subscribe for our next clinical case discussion, and we are discussing each case per day. Thank you.